Up next, we have Dr. Alan Ma. He's a clinical geneticist with the Sydney Children's Hospital Network at Westmead. He has a PhD on the genomics of ocular eye disorders, and he's also a senior lecturer with the University of Sydney. Ladies and gentlemen, please put your hands together and welcome Dr. Alan Ma to the stage.
Thank you to the organisers for having me to speak today. I'm a clinical geneticist, and I'll be talking a little bit about mainly the diagnosis, both current and future, in inherited retinal dystrophies. And I'm going to talk a little bit of an introduction, but you've already heard a very thorough overview of the IRDs, but really focusing on the referral and testing pathways, and also the role of the team in helping to look after patients. So you've already heard that genetic retinal dystrophies are not really that rare. We think around about 1 in 1,000 people are affected by one. And you've seen there some pictures of retina, looking at the issues of degeneration and vision loss that can occur with these conditions. I guess one of the difficulties that's already been highlighted is that there's a lot of genes that can cause these. There's well over 200 of them, and there's a real mix in terms of what the individual genes can cause and what, the kind of clinical picture that can happen. And you can see you'll be shown lots of Venn diagrams today, but this one kind of shows the huge overlap between all the various subtypes of retinal dystrophies, as well as some of the syndromes that can be associated with it. And by syndrome, what we mean is conditions that can cause more than just the ocular features, so sometimes other effects on the brain or hearing and other features as well. And I guess the question is, why is a genetic diagnosis increasingly important? And I think this is a really, really relevant question for now, because of the last 10 years of advances in genomic testing. Really, right now, a genetic diagnosis can really bring some clarity in terms of the specific diagnosis and sometimes some information about the prognosis. It can help identify some of those syndromes that I mentioned that may have additional health implications beyond just the vision. A lot of families that we see, especially young families, are concerned about how likely this might happen again in their next child or in the next generation. And so genetic diagnosis really helps to clarify this and offer couples reproductive options. Increasingly, a genetic diagnosis is going to be used to guide treatment decisions, especially now as we enter the era of gene therapies and clinical trials that are increasingly available, as you've just heard. At the moment, we kind of have this recommended pathway for any patient who is suspected to have retinal dystrophy. Firstly, to see their general practitioner if there are concerns about their vision or if there's a family history of a retinal dystrophy. And they can then refer you to an ophthalmologist to help clarify the diagnosis. The ophthalmologist will examine for the features of retinal dystrophy and hopefully try to work out what subtype clinically might be going on, and then also refer to genetics to obtain a genetic diagnosis. And in genetics, we provide genetic counselling and genomic testing for these retinal dystrophies and follow-up. And really the role of genetics is to both understand the form of inheritance or how this has come about in a family, but also to help explain the intricacies of genetic testing and to talk a little bit about the benefits and the disadvantages sometimes of testing. And really one of the most important points that we bring across to our patients is that testing depends on a few things, and it's not 100%. Having a clear clinical diagnosis, so seeing an ophthalmologist and getting all those tests that John talked about is really, really helpful to help guide the genetic investigations. But at the end of the day, after we've done the testing, there's about 4 possible outcomes. Around about 50 to 60% of the time overall, we find a genetic cause, but sometimes we find something called a VUS, or a variant of uncertain significance, and it basically means we're not sure if this particular gene change is the answer or not. Very rarely, maybe about 1 in 100 times, we find something called an incidental finding, which is a gene totally unrelated to vision loss. It might be a cancer gene or something else that's unrelated, but we feel that we have to tell you because it has important implications for health. And then probably up to about 50% of the time we have an uninformative result. We don't actually find a genetic diagnosis. Also, with over 250 genes to test, we really have to think carefully about how we test and which genes we look at. And we often don't look at all those genes in all patients. So sometimes we stratify by the genetic subtype or the clinical subtype. So here's a table that just explains there's a few subtypes of rod cone dystrophy, cone rod dystrophy, and Leber congenital amaurosis. And some of the key genes that we consider, which then determines the yield of the testing, and also some of the syndromal conditions that we keep in the back of our mind when we do this type of testing. And there are a whole bunch of options available at the moment when we do genetic testing. The commonest thing is to do a panel. And what I mean by a panel is a list of genes associated with a specific clinical subtype, like the ones that were in the table before. Increasingly, we're actually doing whole genomes. And what that means is rather than just looking at the 200 or so genes or 10 genes associated with the specific conditions, we can actually look at all 20,000 of our genes. Now, not all of those 20,000 genes will be associated with the retinal dystrophy. In fact, only a small subset. And so we really have to think carefully before we do this type of big testing, especially about things like what the yield is, what the likelihood of finding an answer is. And very occasionally we sometimes test an individual as a trio. And what that means is an individual with both parents. Now, depending on where you live, there are all kinds of intricacies about where you have testing and what type of testing, but most states have some kind of standard referral laboratory that will do this type of expert testing. And increasingly, there's actually some commercial labs overseas that might even recruit you directly to do testing. Sometimes this testing is free, but we do have some concerns about these labs sometimes because of these free testing and why they're doing it. And really, I guess what we're trying to do when we do genetic testing is really to look for that needle in a haystack. We're trying to find a single spelling change in a gene responsible for the retinal dystrophy amongst all your 6 billion bits of DNA data. This comes with some important implications. And so we always spend a lot of time with our patients going through the genetic counselling issues and really going through the consent process carefully. We usually explain to patients that genetic testing is not always straightforward, as I've explained, and really our understanding and our interpretation of this genetic data is changing over time. It's getting better, but it's taking time. Not everyone we see in a genetics clinic actually receives a genetic diagnosis. And so really that's an important take-home message, because we don't always find the genetic answer. And we sometimes find these fuzzy answers, these grey answers, these variants of uncertain significance that can sometimes cause a lot of anxiety and a lot of distress. One of the key aspects of genetic counselling is that we're finding that this genetic information is very personal, but also family-based. If we find a change in you, it has implications for the rest of your family, your siblings, your aunties, your uncles, your parents. And so we really do spend a lot of time carefully explaining these with families. I'm going to go through a little bit about what we explain to families in terms of how genes are inherited. So I'm going to whiz through genetics for you guys in the next few slides. Basically, we can inherit our genes in 3 main ways. And this is if we have a genetic condition. So these are called autosomal dominant conditions, autosomal recessive conditions, or X-linked. So if we have an autosomal dominant condition, this usually occurs when we have a gene that causes retinal dystrophy, and we have a 50% chance of passing this on to our children. So an individual will have a 50-50 chance for each child, regardless of a male or female child, of passing this on. And these are called dominantly inherited retinal dystrophy genes. The commonest form is probably autosomal recessive, so most of the genes are actually recessively inherited, where an individual has actually inherited a faulty copy of that gene from both parents. So the parents are what we call carriers, so they're healthy, they have a faulty copy of the gene, but they have a normal copy of the gene, and so they'll never develop retinal dystrophy, but there's a 25% chance that they'll pass on that affected copy of the gene in each pregnancy. interesting, I'll put a little side note here, we're actually all carriers for something, so probably about 50 to 100 different genetic conditions. You just don't know it, and you often don't have testing, but this type of testing is increasingly available, and there is actually a national carrier screening program right now that can screen for some of these recessive conditions. And then the final way that genetic conditions can be inherited is something called X-linked, and this is specific to the X chromosome. So males have one X chromosome and a Y chromosome, and females have two X chromosomes. And so usually this is diagnosed when an affected male presents to clinic, and because they have the affected gene on their X chromosome, they can't pass this to their boys. So their boys will not have that X-linked condition, but their female children will all be carriers. They'll all carry the X chromosome from their father. They may or may not be affected, and usually for the retinal dystrophies that are X-linked, they are not affected or can be variable in their effect. But a carrier female can then have a boy who's affected by that condition. And there's about a 50% chance that that can happen. And I guess the question that we get asked in clinic is, we've explained all of these forms of inheritance. What is the point of this? Why do we need to understand this? Well, the commonest question we get asked in clinic is really, what are the chances of either my next child having this or of my children passing this on to the next generation? And so depending on the specific mode of inheritance that I've just talked about, there are various options for family planning. And this is just the options available now. There's an increasing number of these options over time. So at the moment, you could have something called pre-implantation genetic diagnosis, which is basically a process with in vitro fertilization. So they make the embryos in a lab, and you can test those embryos for a specific genetic condition that's running in the family, and only put back the unaffected embryos for the rest of the pregnancy. So that is an option. Another option is to potentially test a pregnancy, so to fall pregnant naturally, and then test the pregnancy from about 12 weeks of gestation for the genetic condition. Now, this is very challenging, especially for retinal dystrophies. And so this would need very careful counselling with the team, with the obstetrics team, and with the patient. And so we really spend a lot of time talking through this with individual families. And really the great difficulty at this stage is that if you don't have a genetic diagnosis and you don't understand how the retinal dystrophy is inherited in your family and how it's going to be passed on, you actually can't access these options. And that's especially the case if you have one of these grey variants, these variants of uncertain significance as well. What we're finding is evolving over the last couple of years in the retinal dystrophy clinic is that we're increasingly needing to combine expertise. And what I mean is that you've just heard from John that the intricacies of the ocular management of these is very complicated, and so is the intricacies of the genetic management of these conditions. And so often we're needing to come together as a team to really discuss patients, either when there's a really complex result or a complex pattern in a family, or just very difficult questions like families wanting more children but not sure about the result. And so what we're increasingly doing is working together to work out the optimal pathway for families, both to get a diagnosis and increasingly to think about what gene therapy options there are. And this is something we've published recently, but we're really we're actually kind of seeing that there really is this essential role of this team approach for patients, that we need to combine the expertise of the ophthalmologists, the patients, the genetic counselling, often the scientists in the lab, and sometimes the researchers as well, and increasingly the gene therapy teams and advanced therapies alongside the genetics to work together to help look after our patients. And really the end goal of a lot of this, and this is what we're trying to push for more and more, is that by working together as a team, we can hopefully provide our patients with pathways, both for them as families, but also for treatments, for management, for clinical trials, and eventually for therapies to help restore vision. I think that's the end of my time.